All right, welcome back. Thank you so much for staying with us. Being a Thursday, we want to talk matters health, and this morning we're shining the spotlight on one of the growing burden of cancer, that is prostate and colon cancer. This affects men, in case you're wondering, but of course you can also be part of this conversation on our socials at TV47 Kenya on Facebook and on YouTube, TV47 Digital on X. My handle is at @Ann_Did, and you can tag me as well. My guest in studio is Dr. Harrison Barry, a resident doctor at HCG Cancer Center, to tell us more about prostate and colon cancer. What is the correlation between the two? This is a growing burden among the men, and why is it growing exactly? What are the men not doing right, and what do they need to change in terms of diet, lifestyle, and everything in between? Karibu sana to TV47 Morning Cafe, Daktari.
Thank you so much for hosting me today, Anne. My name is Dr. Harrison Barry. I am one of the resident doctors at HCG-CCK.
Yes.
So HCG-CCK stands for Healthcare Global.
I was going to ask that. Healthcare Global.
Cancer Care Kenya. So we are currently located at Parklands, Mpisha, just next to Mpisha, Shivachi Road. And at HCG-CCK, we currently adopt a holistic approach to the management of cancers, not just prostate and colon, but a whole spectrum, A to Z. So at HCG as well, we work with our patients. We do not just treat the patient, but also the person for the malignancy. Yes, our story today, we bring a story of hope, a story of resilience, and the new treatments that are currently available for our patients.
Absolutely. So we have a variety of things to talk about, including treatment as well. And like you've mentioned, to, of course, bring hope and not to scare viewers watching from home. Yes. But let's first of all start with definitions, just to, set the pace for this conversation and for better understanding, yeah? Prostate cancer. What is the prostate? And then how does it build into, a cancer?
Okay, so by definition, the prostate by itself is a small walnut gland, size of a pea, that is located in the pelvis, slightly below the bladder, and in front of the rectum. The function of the prostate is to enrich the male reproductive fluid so that it is adequate for reproduction. Okay. By definition, cancers. A cancer is an uncontrollable growth of a specific gland, whereby it decides to even spread from the primary region to distant sites, causing difficulty in organ-related functions. Okay, so in men specifically, the prostate usually enlarges over time. The target age where we recommend screening is anywhere above 45. Mandatory, we start screening from 55. So this is usually testosterone driven. The precursor, which is the condition just before you get the prostate cancer, is usually called benign prostatic hypertrophy, yani the organ in a fura. So the organ starts to swell, and if left unchecked, it now becomes completely cancerous. Okay, so usually the symptoms that are usually most frequently are related to obstruction of the urine. This is because the passage of urine, the urethra is a tube that allows passage of urine. Is usually, there's an area of the urethra that is found within the prostate called the prostatic urethra. So if that area is blocked, now you start getting what men present as, or men define as, lower urinary tract symptoms. This is hesitancy, going to the washroom several times, difficulty in passing urine because of obstruction.
Going to the washroom several times could be a sign of prostate cancer.
Definitely.
All right.
Yes. Also, you can present with obstruction, complete obstruction. We call it acute blood obstruction, or the term is BOO. Okay. You could also have frequent visits at night. We use the term nocturia. In advanced stages, we have blood in urine, which is usually more often a late stage. And when the disease spreads outside of the pelvis, you may manifest with bone pain or back pain. So I would like to tell the audience today that men above 60, if you present with back pain, it is most usually not always arthritis. have your doctor check you, have your PSA, which is the prostate-specific antigen, analyzed.
All
as
right.
a routine.
Now you're talking about 45, 55, 60, thereabout.
Yes.
Why not the 20-year-olds men? Why is it that prostate cancer you recommend for screening and testing from, you know, mid-age, say 45 and above, like you mentioned?
Yes, because there is usually a testosterone surge during this particular time, and this is what derives the organ to enlarge. Okay, so yes. So from 45 all the way, we get a surge in the hormones, and that is what you have.
So does it mean that somebody, just a young man at the age of, say, 20, they're about to somewhere between 40 and 35 there, 30, 40, they don't present with the symptoms of cancer, or they are not at high risk of obtaining prostate cancer? Is that the case?
Thank you for that question. So that brings us to our risk factors. So prostate cancer, aside from age, there are what I would call modifiable and non-modifiable risk factors. So in the non-modifiable risk factors, these are things you cannot alter. You have your age. 2, you have your genetic predisposition. We do have genes, some genetic predispositions, whereby the prostate cancer runs in the family. Utasikia mtu akikueleza that my grandfather had obstruction, but we didn't know what it was. My father also had similar symptoms. Things were not very clear. So in that family, we have a history. So from the medical side, we do have genetic tests that we run. An example is BRCA1 and 2, similar as the ones that are found in breast. And these are able to predispose you even early enough, because it's something that runs in the family. Yes, so that answers your question. All
right, now talk to us about colon cancer. We are talking about prostate and colon cancer. So what is the correlation between the two? We've talked about prostate cancer, that is out of the way. You said the symptoms that are there that somebody should look out for. But how about colon cancer?
Okay, so again, the colon is the large intestine to start with. And again, a malignancy is the uncontrolled growth of cells within the large intestine. The correlation between prostate and colon mostly lies in the genetic, buildup, and number 2, we also have now the modifiable risk factors. You remember I say that in the risk factors for prostate, we have the modifiable and the non-modifiable. So the modifiable are the lifestyle changes, the things that you can change. So here we have lifestyle, obesity. We have things such as binge drinking, we have smoking, and now finally in the non-modifiable we have our genetic predisposition. Yes, so whenever we find that in a particular family or in a particular individual, we have one or two malignancies, we recommend what we call familial screening or next-gen sequencing for that family. This is a series of tests that are run so that we can able to identify these mutations, then we can able to treat the disease. Yes.
In early stages. So in real sense, if you're talking about you can be able to treat diseases before it, it explodes into something bigger, is it possible to cure cancer in early stages? That is something that, a lot of people ask. Yes, there is treatment options like chemotherapy, which we will get deeper into them as we continue this conversation. But say you detect a possibility of a prostate cancer being in this family. Is it possible to completely cure it, or is it just about prevention?
Yes. So prostate cancer in early detection, that means the disease is localized within the prostate, even at times outside the prostate, but within the pelvis, we can be able to achieve complete, the word is remission, and control the disease. So in the management of early disease in the prostate, we usually have 2 techniques. One is radiotherapy or surgery in the definitive approach. And the second one is hormonal treatment. So hormonal treatment runs throughout all stages of prostate cancer. Can be short-term, can be long-term. Now, when it comes to the definitive treatment which we approach, we can either do what we call a radical prostatectomy, that means removal of the prostate itself and the surrounding lymph nodes, or you can adapt for what we call definitive radiotherapy. Okay? So currently at HCG we are doing radiotherapy, definitive radiotherapy with majorly 3 techniques. We have the 3D, we have the VMAT, which is targeted, minimizes side effects, and we have a technique called SBRT, which offers excellent results and almost 99% cure rates. Yes.
Usually we hear about, I want to draw comparison from cervical cancer, that sometimes men are the carriers and, you know, they give the women cervical cancer. How about prostate cancer? Is there anything to do with somebody being a carrier and then transmitting it to, you know, the man, or is it just about being hereditary?
So prostate, fortunately, first is not transmissible because the risk factors, you said we have age is non-modifiable, we have the genetic mutations can be passed from family to family, but not transmissible from one person to the other.
So there's nothing like carriers in prostate cancer?
Cervical, we do have HPV, I think the versions of 16 and 18, which now can be transmitted and are known to transmit the disease. Yes.
Are you seeing a rise in the cases of prostate cancer in Kenya and Africa as a whole? Or is it something that has always been there, but we never used to talk much about it? Is there a rise, or are we talking much about it?
So yes, we do have a rise. Currently, the annual rate, what we call the incidence, the detection of new rates in Kenya, we are having 3,400 new cases of prostate cancer. For us as a facility, it's both an educative point because men nowadays are coming forward early. We are seeing a lot of early disease as opposed to previously when we used to see a lot of advanced stage diseases. Right now we are seeing a lot of early disease and we are really happy to treat. Yes, so I think it is more attributable to the screening programs and the outreach that we are actually doing.
All right.
Yes.
So if you're saying there's a rise in the increase of prostate cancer in Kenya, for instance, and WHO says it accounts for around 21% of new cancer cases in males, that is prostate cancer, then what is spiking this increase?
Okay, I think it is the screening that we are doing. The cases, I tend to think they have always been there, but we are having a lot of screening, so we are able to detect these cases that were previously undetectable.
By spiking, I mean, what are the men doing that is making, you know, prostate cancer become more prevalent, you know, among the male gender?
Okay, so the more we go for these outreach programs, we explain to individuals and these men that prostate cancer presents in this particular way. If you see it, we try and destigmatize the treatment options, the approach. Do not be afraid to tell your family members that you're facing these particular symptoms. I have seen some cases whereby men are very quiet. You find that the gentleman has had obstruction for 3 months. He does not want to come out. At the 4th, he decides to come out. And good enough, we detect this early enough. Okay, so the more we explain to men the importance of going for early screening, especially with what we call PSAs, and also our doctors, our nurses, they're also able to pick up these cases very quickly. This person is presenting with these particular symptoms, and they forward them to the relevant teams for management.
All right. Now, lifestyle has always been linked to, you know, cancer risks. What are some of these habits that you see men are having that are putting them at risk? Say, we hear about maybe alcohol could spike a certain kind of disease, about prostate cancer and colon cancer in general. What are these lifestyle, you know, habits that you're seeing in men that are contributing to the rise of prostate cancer?
Okay, so here we are looking at number 1, binge drinking. Alcohol is known to contain carcinogens. So in colon specifically, long-term use of alcohol is going to predispose you to what we call irritable bowel disease and also new growths, which we call polyps. Okay, so irritable bowel disease is the precursor. These small polyps that form are usually the precancer states of colon cancer. In prostate, it is also associated with carcinogens, which are known to increase the mutation rates of these cancers. Okay? The checkpoints at which the cell is supposed to control the growth of the cell, this checkpoint becomes deficient, and so the carcinogen triggers the uncontrollable growth of the cells. Number 2, smoking. Smoking has always been associated with not just prostate and colon, but I think almost all types of cancers. So I think if you're in a position to quit smoking, that should be the best approach. Number 3, we are seeing some new information regarding red meat. I think that one is very important to mention. So the current European Society of Medical Oncology advocates that you should consume half a kilogram of red meat, preferably within a week, a maximum of half a kg. This is because when red meat is heated, it also releases some carcinogens. Okay, but because we cannot fully avoid red meat, that is why we are given the allowance of roughly half a kg within a week. Number 4, we are looking at processed foods, which have become very common. Again, the European Society of Medical Oncology Nutrition mentions German sausages. I think, I do not want to quote the brands, but you know, the Smokies and the likes. So these ones, again, these are preserved foods. So usually the preservatives, we are looking at the nitrites. The nitrites, the preservative that is used, these are also active direct carcinogens. So over time, the accumulation of these carcinogens trigger the uncontrollable growth of a cell. So it could be the prostate, it could be the colon. Yes.
All right, and I was looking at something here, and it says prostate and colon cancer. One diagnosis may increase the risk of another. So how is that relation exactly? Explain it to us.
Okay. There is no direct correlation that if you're having prostate, you will definitely have colon. We do treat a lot of prostate cancer cases, and we screen for colon. Usually at times, some of the small side effects of radiotherapy, you could have rectal irritation, okay? But that does not necessarily mean you'll have colon cancer. We do see a lot of individual prostate, we do see a lot of individual colon cases, but whenever we find the two, we have to do genetic screening, because now the specific mutation is what we have to address. Yes.
We've also had concerns around misdiagnosis of a lot of diseases. Sometimes when the men go there, or maybe when they're at home and they think, you know, they're feeling these symptoms that you're saying, there's obstruction and the prostate, and they think that maybe they're just having a urinary tract infection. So have there been cases of misdiagnosis when trying to identify chances of there being prostate cancer or colon cancer?
Yes, we do have a few unfortunate cases that we see. The unfortunate cases that we are talking about mostly lie, as I've mentioned previously, the back pain. Back pain is usually the commonest misdiagnosis. Patients will present with back pain, and the age that you're dealing with is 50 and above. You will tend to think that this is actually osteoarthritis, and even when you do an X-ray, you do get features that are similar to osteoarthritis. So most patients will be placed on physiotherapy and the likes. I believe currently, in regarding to the obstruction symptoms, whenever we have a male of that particular age group, 45 and above, who presents with the lower urinary tract symptoms, any pain while passing urine, increased frequency, blockage, blood in urine, as much as we screen you for urinary tract infections, we also advocate for a PSA and what we call an ultrasound, so that we also assess the prostate immediately. Yes.
We're talking about diagnosis. So how accessible diagnosis treatment for, say, prostate and colon cancer here in the country? I know you say that in HCG you do offer this, but let's look at it from a broader perspective. People living very far away from Nairobi, this institution is in Parklands. I don't know if you're in Kisumu, if you're in Mombasa, Wajir, those other areas. But how accessible are diagnostic tools for prostate and colon cancer in Kenya?
So currently, yes, the diagnostic tools, and both the diagnostic and the screening tools are available. Routinely, we start with a history. For screening, you know, a history and a physical examination. I believe that on every individual, every medical practitioner, be it a nurse, be it a doctor, be it a clinical officer, a consultant, they can be able to take a history. As we've mentioned, the above symptoms, the urinary tract infections, those ones should be able to be picked out very early, and follow-up is given. Number 2, we have PSA, the prostate-specific antigen. This one is also widely available. Currently, SHA covers PSA at least once annually in the new oncology package. So I believe it should be available. Yes. Number 3, I believe most level 4, level 5 hospitals do possess an ultrasound. So they can be able to quickly and routinely assess should there be need. It is not routinely, but should the need arise, you should be able to do an ultrasound. From there, we are looking now at the tertiary centers. Once the diagnosis has been made, you're now referred to the tertiary oncology centers. So here currently in the country, we are having around, I think, 5 PET scans. HCG has also brought a PET scan. We do have the gallium-68. It is a new radio tracer. As opposed to the previous radio tracers, we used to use FDG, which used to take long preparation time. We also had challenges with patients with diabetes. Gallium-68 can be routinely injected, and in around 30 to 40 minutes, we can be able to do what we call a PSMA PET scan, which is very sensitive. So currently, our PSMA PET scan is also covered by SHA. So once the diagnosis is made, we can be able to stage the disease clinically and forward you for treatment again for radiotherapy and hormonal treatment, which is also covered by SHA again. So treatment, yes, is available, screening is available, yes.
Treatment is available and screening is available, then how affordable is it if you're talking about SHA is covering that? And I'm looking at it from the defunct NHIF, and that was reduced. Let's just go a little critical kidogo. It was reduced. In NHIF, it was around 1.2 million shillings. Right now, SHA is offering around 500 million shillings. Then what does that do, to the cost of treatment? It's there, yes, but how affordable is it for people who, cannot afford it, or people who are used to, have these oncology services done every now and then? But now this we see SHA has reduced it, 500 shillings. That is like 500,000 plus. Then what does that do to the cost of treatment?
Definitely, there will be some small challenges in the treatment escalation, but in the initial stages, this means that you have already made your diagnosis. We do offer what we call hormonal therapy, which I believe is very affordable with SHA. We do take SHA, it is very affordable. It is covered within the package and can last you for that duration. Also for radiotherapy, I mentioned we have 3 techniques. We have 3D, we have VMAT, and we have SBRT. So 3D, VMAT, they are both covered by SHA well. So yes, patients should be able to be treated within the SHA package. Yes. All
right. So talk to us about treatment in broader perspective. How long is treatment, and step by step, what does it look like for these patients with prostate and colon cancer? Let's start with prostate, and then we can do colon.
Okay, so for prostate cancer, treatment, I will categorize prostate cancer into 3 for ease of mentioning the treatment. Okay. So we have local disease. In local disease, the cancer is within the organ, it has not spread out. In locally advanced disease, the disease is outside the prostate, maybe into the seminal vesicles, maybe also into the surrounding lymph nodes, but within the pelvis. The pelvis is this region. And then now in advanced states or metastatic is when the disease is the disease is within the bone. That is usually the first area it goes to, or maybe in the lungs and the likes. Hormonal treatment is standard throughout. In local disease, it is short term, 2 years. Again, in locally advanced, 2 years. In metastatic, we might decide to go throughout till the end with hormonal treatment. For local and locally advanced, we do offer definitive radiotherapy. That means the intent is to cure, and we do achieve good curative rates. However, for metastatic setting, we can choose hormonal tablets alongside the hormonal injection, plus or minus chemotherapy, plus or minus palliative radiotherapy to relieve the patient of symptoms. Yes, I think for us, notably to mention, prostate cancer is a slow-growing tumor. For us, once we find you even in advanced stages of prostate cancer, for us it's not the end. It is the beginning of a new life. Okay, we know the disease is slow-growing. We try as much as possible to contain the disease so that it does not spread. Okay, And also we give you treatment that is tailored specifically for you and not generalized. Yes.
All right, that is for prostate cancer. Then how does treatment look like for colon cancer? What is the first step right from, diagnosis to the time where, you have now the diagnosis on table, and then the medicine that you give them and how you take them through everything that they need to know and how to take care of themselves even when they go home?
Okay. Colon cancer is slightly different from prostate. We are seeing, I will categorize it both in males and females. In females, we are seeing a new incidence. That means the new cases are found in younger women, whereas in males, we are seeing it again in the region between 40 and above. In regards to treatment, again, I would stage it as local disease. That means the disease is still within the colon. We have locally advanced, again, which means the tumor is inside the colon and the surrounding lymph nodes. And from there we have the metastatic setting where the disease has spread. In local disease, we do offer upfront surgical oncology surgeries. That means we remove the tumor first, and then we can, based on what we call a histology report, once we have removed the tumor, we take the mass for analysis in a lab. So once we take it to analysis for a lab, they'll be able to tell us the tissue type and whether there is need for additional chemotherapy or not. In locally advanced stages, we might decide to either do surgery first or chemotherapy to shrink the tumor. We usually call it neoadjuvant treatment. And then from there, do the surgery. Again, take the mass to the lab for what we call a pathology report, and then decide if there is need for treatment, chemotherapy afterwards. For metastatic disease, here again we offer two modalities of treatment. We are looking at either palliative surgery in most cases or chemotherapy, because the disease has spread in different areas. So to be able to remove the tumor in all these areas, at times it's challenging. That's why we go for, first of all, chemotherapy. Also, notably in colon, it's one of the tumors that has been associated with genetic mutations, and we are able to screen routinely for this. We have around 5 mutations. We're able to routinely screen, and they do respond very well to immunotherapy, again, which is covered by SHA. Okay? Yeah, so immunotherapy is a strong option for colon cancer, as opposed to the likes of prostate and other tumors. Yes.
And when you talk about colon cancer, sometimes people assume that things like, say, constipation, that this is just something that is normal. Say constipation and, of course, stomach discomfort as well. Is this something that should be a red flag for the men? Something that should make them seek medical advice?
Definitely, definitely. And colon cancer, unlike prostate, is usually discovered most of the time in stage 3. This is because in our setup, people, as you mentioned, will present with different challenges, slight abdominal pain. We have the term acidity or gastritis in our setup. We have irritable bowel disease. So by the time you're presenting with late stage features of colon cancer, which in most cases is blood in stool or weight loss or fatigue or unable to pass stool, that is when people rush to hospital. So whenever you have abdominal or stomach challenges, you've been treated the first time and the second time, it is important to follow up with or to escalate the point of care. Maybe from, if you're dealing with lower staff, you can go to senior staff. You can have what we call a colonoscopy done. It's usually an endoscopy. An endoscopy contains colonoscopy plus an OGD. So they insert a tube from the mouth. They can also choose to insert from the rectum. Let them screen. If there are any precancerous masses or lesions such as the polyps I had mentioned, they will be able to remove them, take them to the lab for analysis. Okay? Yes.
So colonoscopy is feared to be very, painful. Sometimes men try to avoid it. Then how do you tell them that this is very important in detecting if at all one has colon cancer?
So yes, previously it was slightly...
First of all, is it painful?
No, it is not painful. colonoscopy nowadays and also endoscopy is done under what we call sedative anesthesia. So there is a pre-workup that you have to do to empty your bowel, to starve maybe for 4 or 5 hours. From there you're sedated. Okay, so that means you will enter into a surgical setup. You're given the anesthesia and you will be out for the next 1 hour. And there will also be doctors to check up on you. That is the anesthesiologist and the surgeon who's doing the colonoscopy. So once they do their screening, they will report on their findings, and from there you will just wake up 1 hour later having been screened without any challenges. So it is not painful nowadays. It is done under anesthesia.
Technology has come to help.
Definitely.
You mentioned something about PSA, that is prostate-specific antigen, PSA.
Yes.
And this has been recommended for, prostate cancer testing. And concerns around, I know men have that there could be, say, positive or false results after that.
Yes.
So is it a reliable method of testing for prostate cancer?
Okay, that's a very important question. A PSA is a hormone that is secreted from the prostate cells. And most of the time it is secreted in times of distress. Okay? So cancer is one of the distress mechanisms. You could also have, we are seeing increase in rates in what we call prostatitis, which is an infection of the prostate. States such as trauma, if you've had injury to the pelvis and the prostate is affected, it will also release the PSA. From there we have also a few instances of ejaculation that increase the rates of PSA. What is important is, they said you have to correlate between the history, the PSA levels, and then from there you can be able to make a diagnosis. Usually the PSA itself has levels, so 0 to 4 is within normal range for most men. 4 to 10 indicates that there is a lesion. It could be the things we mentioned. It could also be the precancerous state that I had said, the benign prostatic hyperplasia, BPH. But definitely PSAs above 10 do warrant further investigations. So routinely, if you've had any of these during the history and examination, slightly elevated PSA, then for sure you need evaluation. If you only had an elevated PSA, that one can be followed up. Okay? Yes.
So for men who feel healthy and, have no symptoms, the symptoms you've talked about are the ones for prostate cancer and of course colon cancer as well. And, they are very reluctant in going to the hospital to have themselves checked. Then how important is routine screening and how long should it be done?
So for men above the age of 45, we do recommend annual screening. I usually like to point out that whenever you're taking your car for service, or yes, your car for service, I know men love to take their cars for service routinely and they never forget. Go get your PSA checked. We have seen what we call incidental findings of prostate cancer. That means very, very early disease to the extent that it cannot even present with symptoms. This is something purely incidental, and in such kind of cases we are usually very happy because we can treat this disease completely. So screening is very, very important for both males and females, especially colon. I know people do not like going for the colonoscopies, but it is very, very important because if we're able to detect these illnesses early, the curative rates are also very, very high. Yes, so screening is very, very important. All right.
Yes. So for the men above the age of 45, that is annually. But you're saying these men below 45 years, they don't have to do screening?
Not really, because they are not in the target. They are not in the target risk group unless there is a family history. Strong familial history is when you can come for advice. You know, when you visit your doctor, there is a section they have to inquire from you. We call it the family social history. They have to ask, are there any illnesses that are running in your family? And what kind of work do you do? Okay, so that family social is very important. If we hear there's maybe 1 or 2 incidences of prostate cancer in the family, we can now be able to advise you on earlier screening and educate you on the symptoms.
You mentioned work history. Does it come to play as well? What work do you do in regards to testing for prostate cancer?
Not really. Work history, not really.
All right. Talk to us about, for women, for cervical cancer, they recommend that we should go for pap smear. Then what is the opposite of pap smear for prostate cancer and colon cancer?
Okay, so that is a PSA.
Prostate specific antigen,
yes,
and colonoscopy.
Yes, and colonoscopy. Those are the recommended screening tools. In colonoscopy, we are seeing what we call FIOBT, which is basically fecal blood. This is fecal blood. You're having blood in stool. It is not routinely done because you cannot keep on doing regular stool tests just to look for blood. So we usually advocate that whenever you feel that you're having any abdominal symptoms, as much as you're going for the FIOBT, also have a colonoscopy that is done, because colonoscopy is the gold standard. Because once they insert the tube goes taking images and can be able to collect a sample. There could be many causes that will lead to blood in stool, not just colon cancer. Yes.
All right. Now speak to us about treatment options that are available locally. You've already diagnosed this patient. Say the early stages and the advanced stages, how does treatment look like and what do you give these patients? I know there's something to do with chemotherapy, but aside from chemo and chemo as well, don't put it aside, chemo as well. So what are the treatment options for prostate cancer and are they similar between prostate and colon cancer?
So for prostate, the main treatment, again, I mentioned we have surgery or radiotherapy. Most men tend to lie within radiotherapy because of the side effects of surgery. Number two, we have the constant hormonal treatment. Hormonal treatment is mandatory because we say that there is a testosterone surge during a particular age group. So we have to be on hormonal therapy. We have to be on either radical prostatectomy or radiotherapy. At HCG currently, we do offer both services for radical prostatectomy and mainstay radiotherapy. For radiotherapy, we have three techniques. We have the 3D, we have advanced VMAT, and we have advanced SBRT. SBRT achieves the highest form of success with over 98% cure rates. So here you do the high-dose radiotherapy to the prostate only for 5 days, and you're done. You're completely cured. VMAT takes slightly longer, or we can do between 20 to 25 sessions, depending on need basis, while 3D is the older conventional technique that takes around 28 to 35 sessions. Yes, but very well tolerated.
Talk to us about the side effects. You hinted about that sometimes there could be side effects from treatment, and a lot of men worry about them being infertile or, treatment affecting their sexual health in general. Then how do you walk them through that procedure? And does it really and actually affect their sexual health in the long run and completely?
So yes, and it does affect their sexual health, but in prostate management or prostate cancer treatment, our definitions of infertility are slightly different from what the medical fraternity will term a person being infertile. We mentioned that the mainstay is hormonal treatment. So we do try as much as possible to reduce the testosterone levels. This will reduce what we call the erection strength. But also to counteract that, we do offer some medication options within certain dosages to be able to cover for this particular deficiency, so that you're no longer fertile, okay, or no longer facing erection challenges, okay. When we are unable to do that, we do refer you to one of our own urologists who are able to now further explore treatment options. Yes. So what the normal population will term as ED, for us is not ED, because we counteract that effect of both hormonal and radiotherapy with our own medications to be able to support that. Yes.
So if a patient has prostate cancer, from what you're talking about side effects, sometimes you try to prevent them from having an erection or from them, you lowering the testosterone hormones. So does it mean that they cannot at all engage in sexual intercourse?
They do. And with our support, with our medications. Not all of them are going to absolutely suffer from ED, which is erectile dysfunction. But those who do, we do offer supportive medications, and they do continue with their sexual activity. Okay. Hormonal treatment also is known to lower the libido because the hormonal treatment options that we use are the same that we use in breast and the likes. So they are known to reduce the libido, and still for that we have medications, we have lifestyle changes we can be able to advise you on what to do. Okay? Yes.
All right, and there's a question here, very interesting one for you. And he's saying, Dr. I've had the prostate cancer treatment. I've heard that prostate cancer treatment can make a man impotent. Is that true, and how do you help patients deal with that?
Okay, so what happens is the prostate is responsible for producing what you call the prostatic fluid, which basically enriches semen, which is going to fertilize the ova. So what happens is when we radiate the prostate and at times the seminal vesicle, that prostatic fluid becomes deficient. So yes, infertility can be a side effect, and we do have counseling sessions prior to HCG so that we also explain to you before we start treatment what we are intending to achieve, and also our curative rates on the same. So yes, infertility can be a side effect, but not erectile dysfunction.
All right.
Yes.
Thank you so much for that question. His name Wanjala. Asante sana for that question. But you know, we've reported cases where, you know, men's health-seeking behavior is very, very poor. And we're talking about cancer. This is 21%. It accounts for 21% of new cancer cases in males, which is quite very high, prostate cancer. Then why are men very reluctant in coming for, you know, diagnosis and screening for cancer? Why are they reluctant? Is it about treat cost, accessibility, or what would you attribute that to?
I would like to divide it prostate and colon individually so that I can address. So let me begin with prostate. Men are very reserved generally when it comes to their sexual health. So by the time symptoms are catching up, they have tried Googling, they have tried visiting other places before the problem actually erupts. So yes, the health-seeking behavior in men has been a challenge, but over the years, over advocacy and explaining the need and also the side effects of having to reserve yourself with this disease, we are seeing a lot of people come out and explain to us their symptoms before, and we can be able to address them. In regards to the colon, again, colonoscopy previously was termed as it was not a very comfortable procedure because you have to insert a tube. At times, previously, sedative anesthesia was not enough. So those were the challenges that made men feel that, you know, we cannot be able to do this. Also, ladies felt that this is very discomforting. But right now, with the current advancement in technology, we can be able to sedate you, get your sample while sedated, you wake up and you go home. Yes.
As someone in the the health field, and you deal a lot with cancer patients, what are some of these myths and misconceptions around prostate and colon cancer as well that you've had and you'd love to demystify today?
I think the biggest challenge and myth that I have found is when it comes to herbal treatment. We do receive a lot of herbal treatment cases whereby a patient has tried stinging nettle, I think usually comes up as number one, or traditional healers, and you find the patient at the time did not have advanced symptoms based on what they're explaining in terms of the history. By the time they're coming to you, you already have advanced stage disease. So I'd like to urge our viewers today that herbal treatment is not an option currently for prostate and colon cancer. Yes. And number two, there is a myth that comes up that prostate cancer, colon cancer treatment is very expensive. As I've explained to you, we do offer options even for SHA. to purely cure the disease at HCG-CCK. So you can visit us for a consultation and we'll be able to demystify this as well.
Now we've talked about screening, that they're coming for screening, yeah? But are they coming to these tables where conversations around prostate cancer are being held? Say, for them just to have this knowledge about prostate cancer and how their body will be if at all, somebody has been diagnosed by, with prostate cancer. So are they coming to these conversations?
Yes, we are seeing a lot of new conversations, not just limited even to prostate, but also to other cancers as well. Colon is emerging, esophagus is emerging. Patients want to know more about what is happening. I think a few relatives have also asked me for what we call the Kenya screening guidelines. I believe they are available on the GOK website, Ministry of Health website. People go through these guidelines and they're also able to understand what we're explaining to them, how soon to screen and how soon to follow up. Yes, we are doing a lot.
All right. There's another question here for you from James. And I'm in my late 40s and I feel fine. I've never gone for cancer screening because I think if I don't have symptoms, then I don't have cancer. Am I wrong? That is the question from James.
So the recommended screening age, James, we begin from 45, but it is very important to know about the familial history and the way the illness presents. Okay? From 45 is when we recommend regular annual PSCs done, and at least a history and a physical assessment as you're going for your checkup. Okay? Less than 40, I think we'd rather advise you more or less on the symptoms so that you can keep up to check with them. Okay? Yes, we're looking at the lower urinary tract symptoms, weight loss, fatigue, back pain. Yes.
All right. And Siwaga is saying colonoscopy and PSA tests are important, yes, and expensive. So what happens to ordinary Kenyans who cannot afford these tests? Do they just wait until it's too late, Daktari?
So as I had previously mentioned, one myth is that cancer treatment and cancer investigations are expensive. The current oncology package covers for annuals, one household member to get annual PSC screening and also colonoscopy. The government advocates or covers for at least 3/4 of the charges. Yes, when the symptoms are present and justifiable, the SHA does cover at least 3/4, yes.
All right, and finally, Samuel is asking, some of us believe that cancer treatment like chemotherapy is worse than the disease itself. What's the truth about side effects and recovery?
Okay, so chemotherapy, yes, does have some side effects. Chemo is not a general term. It's not that we have one particular drug that covers for everything. We have different classes of drugs. Even immunotherapy, which has very few side effects, is still part of chemotherapy. Okay? Even hormonal treatment is still part of chemotherapy because you're targeting the cancer cells, but just in a hormonal way. In prostate specifically, the choice of chemotherapy is one of the friendliest regimens that I have actually witnessed. Patients finish the 8-9 cycles with no major challenges. They usually do expect a little bit of fatigue. The blood cells might be affected. We do adjust doses for that as well. And then you have the common things that people know: hair will fall off and maybe drug deposition in the nails. Yes, but in prostate cancer, colon cancer, we have some of the friendliest regimens as opposed to other cancers that you need to give those dense regimens. In prostate and colon, we do have some of the friendliest regimens. And number two, in both prostate and colon, our choice of chemo, the aim is actually to debulk the disease. So chemo, within the first 4-5 cycles, our patients do report actually significant improvement in symptoms. We do get you out of a crisis. And then from there, once you're stable, we do around 6 to 10 cycles of chemo. From there, once you're stable, we actually switch you to tablets, like in the case of prostate. And then from there, you continue with your life, just taking tablets. Yes.
All right. So in your final remarks, what would you started by saying that you want to give hope to, you know, the men and those with prostate cancer and to let them know that this is not a death sentence. What would you say to people who are reluctant, first of all, in regards to screening and treatment? Colonoscopy has been raised a lot as one of the biggest challenge for the men. They think it's painful, but of course you've talked about that. So what would you say to them, people watching at home and hearing you talk about prostate cancer and colon cancer this morning?
My word of encouragement to our viewers is that tumors or cancers are actually curable. The earlier you find the disease, the higher the chances of curing the disease. The only way you can find a disease in the early stages is through screening. Okay, so you can come to HCG, we can offer screening, we can offer early treatment, early investigations with our PET CT scan, with our LINAC machines radiotherapy, and we do achieve curative, higher curative rates. Yes. I think that's
all right, thank you so much, Dr. Harrison Barry, resident doctor at HCG Cancer Center here in Nairobi. We do appreciate you for making time and taking us through prostate and colon cancer in men. Asante sana. You're watching Morning Cafe. That brings us to the end of this segment. My name is Anne Odida. Stay with us.